Hello everyone, I'm Dr. Rohan Khandelwal, your surgery faculty. So let's start with the first question. The first question was that a patient presented to the casualty with abdominal pain and vomiting. The CT scan image was shown. What is the provisional diagnosis? So if you see the CT image in this patient, you will see in this patient that this patient here has a stone in the gallbladder, right? Now this stone in the gallbladder, you know that majority of the gallstones, they are not radiopaque, but 10% gallstones can be radiopaque, and these radiopaque gallstones can give a Mercedes Benz sign, especially if it's a triradiate stone. Then it can give rise to a Mercedes Benz sign, as you can see. If it is a biradiate stone, it will give rise to a seagull sign, which has also been asked previously in the exam, right? So this is a case of gallstones where this is a radiopaque gallstone and you see the Mercedes Benz sign in these cases. Now, normally gallstones can be pure cholesterol stones, which are rare, they're usually solitary. Mixed stones are the most common overall, and pigment stones are the ones which are most common in Asia. Now, pigment stones are ones which have less than 30% cholesterol, and these can be of two types. You can either have a black pigment stone or a brown pigment stone. Now, a black pigment stone will form when there is hemolysis, when there are hemolytic disorders, and this is usually insoluble bilirubin pigment polymer along with calcium phosphate and calcium bicarbonate. Right? This can be seen in hemolytic conditions like sickle cell anemia, hereditary spherocytosis. Brown pigment stones are seen in infected bile, which can be due to clonorchis or with cholangitis, and this is a combination of calcium bilirubinate with palmitate and stearate as well. The second question, a patient is referred with variceal bleed which is not responding to medical management. Which of the following is a contraindication to the required management? Now, this patient has variceal bleed. We know variceal bleeds are seen in portal hypertension, right? So, when there is portal hypertension, patient can develop esophageal varices and there can be upper GI hemorrhage. In these patients, we first try medical management. We try banding and sclerotherapy with endoscopic management. And if two trials of endoscopic management also fail, then we have to carry out some other intervention. And what is that some other intervention? We need to decrease the portal pressure. And to decrease the portal pressure, we need to carry out a shunt. And the shunt which we usually carry out in such a situation is called TIPS. TIP stands for transjugular intrahepatic portosystemic shunt. So basically what we are doing is we are putting a shunt between a branch of the portal vein and a hepatic vein so that the excess portal pressure can be shunted into the systemic vein. Now, TIPS is a type of a non-selective shunt. Non-selective shunt means that here we are shunting a branch of the portal vein. Here the portal vein is already joined, so it is getting blood from the spleen and from the bowel as well, right? And the blood which is coming from the bowel has toxins in it. So now this toxin rich blood is being shunted into the systemic circulation, which is why the early complication is rupture of the capsule, and that can give rise to bleeding. These patients can even develop encephalopathy because of the toxins which are being shunted into the systemic circulation. But the most common late complication is blockade of the shunt. The shunt can get blocked, and if the shunt gets blocked, what is going to happen? The pressure again will increase, and that will give rise to rebleeding. Now, the question they are asking here is that when will this be contraindicated? So, this is contraindicated when there is a complete portal vein occlusion. Now, if there is a portal vein occlusion, what will you shunt? So, earlier, complete portal vein occlusion was considered as a contraindication. Although there are a few studies which say that now it can be done, but for your level, you should know that a portal vein occlusion is a contraindication for TIPS, and TIPS is a non selective shunt. This is the third question which has been asked quite a few times in the exam. In this question, they are asking, in the given gallbladder, what is the condition which you can see? And you can see that this gallbladder has been dissected, it has been cut open, and you can see these yellow specks in the wall of the gallbladder. This is a classical sign of cholesterosis, which is also known as strawberry gallbladder, right? And this cholesterosis or strawberry gallbladder is when there is deposition of cholesterol crystals in the wall of the gallbladder. And I want you to know that cholesterosis or strawberry gallbladder does not increase the risk, right? Does not increase the risk of gallbladder cancer. This I want you to remember. Now, you know that if there are gallstones, the investigation of choice for gallstones is an ultrasound, and ultrasound abdomen will show a stone in the lumen and it will show a post acoustic shadow, means it will show a blackish shadow post that stone. If you compare it with a polyp in the gallbladder, these are polyps in the gallbladder, and I've shared in my video that I also have polyps, and these are small polyps which I just keep on monitoring, but polyps are not going to show a post-acoustic shadow, and that is how we differentiate a stone from a polyp on ultrasound. This is a gross image of a gallbladder polyp, and you should know that gallbladder polyps, if they are more than 1 centimeter or 10 millimeters, then they are more likely to get converted into malignancy. And if they are more than 10 millimeters or 1 centimeter, then you should carry out a cholecystectomy in such a patient. This is the next question. A patient already diagnosed with inflammatory bowel disease. So they've given a hint here. The patient has an inflammatory bowel disease, comes with recurrent fever, pruritus, and chills. MRCP image is shown here, right? So this is classical of multiple strictures in the biliary tree, and these multiple strictures or this beaded kind of an appearance, right? You can see in primary sclerosing cholangitis, which can be associated with inflammatory bowel disease. And this primary sclerosing cholangitis increases the risk of cholangiocarcinoma. Cholangiocarcinoma is carcinoma of the biliary tree. Now, you should also know that primary sclerosing cholangitis is one of the extra intestinal manifestations which does not resolve after surgery. So there are two extraintestinal manifestations in inflammatory bowel disease which don't resolve after surgery. One of them is primary sclerosing cholangitis and the other one is ankylosing spondylitis. Oriental cholangiohepatitis is seen due to clonorchis infection, right? And Caroli's disease is a type 5 choledochal cyst where there is dilatation of the intrahepatic portion of the biliary tree, that is known as Caroli's disease, and that has also been asked in the exam. Now, you should also know in these patients that this primary sclerosing cholangitis can give rise to cholangiocarcinomas, and that also we will pick up by MRCP. This image is of MRCP, which is magnetic resonance cholangiopancreatography, and later on in this discussion I will cover with you what are the indications of MRCP and ERCP. The next patient is a diabetic patient who comes with these lesions. The patient has these typical rashes. She has a drug history of SSRI intake. She's also had multiple episodes of deep vein thrombosis. What is the most probable diagnosis? So this case is a classical finding of a glucagonoma. In glucagonoma, you can get a necrolytic migratory rash, right? You can get diabetes, right? Diabetes, dermatitis, which is a necrolytic migratory rash, which you can see. There can be deep vein thrombosis or migratory thrombophlebitis, and there can be depression, which is why the patient was on SSRIs. And these four signs are classical of a glucagonoma. Insulinoma, you know, is the most common pancreatic endocrine neoplasm, And this is going to come with Whipple's triad. Whipple's triad we've already discussed. There is fasting hypoglycemia, blood sugar is less than 40, and there's rapid resolution on giving glucose. But these patients will also have a high fasting insulin levels, right? Normally, in all of us, if we are fasting, insulin levels will be low. When will insulin rise in the body? When we are eating something, when there's sugar in the body. But normally, in fasting, insulin levels are low. But in these patients of insulinoma, the fasting insulin levels will be high. VIPoma comes with WDHA syndrome or Werner Morrison syndrome. This is watery diarrhea, hypokalemia, and achlorhydria. This also has been asked in the exam. And from gastrinoma, what has been asked is the gastrinoma triangle. This gastrinoma triangle is also known as the Passerose triangle, and majority of the gastrinomas, almost 65 to 70% of the gastrinomas, arise from within this triangle. This is a simple question. A patient presented with epigastric pain. There is history of alcoholic binge followed by acute abdominal pain few weeks ago. So they are saying that there was a binge drinking, then abdominal pain few weeks ago. Now the patient has come with a mass in the epigastrium and the CT is shown below. This, all of you know, is the classical finding of a pseudocyst. Pseudocyst most commonly is seen in the lesser sac. Now you know lesser sac is the space behind the stomach. So this is the stomach space behind the stomach but in front of the pancreas. That is the lesser sac and the most common site for a pseudocyst or a false cyst to form post pancreatitis. So this is a pancreatic pseudocyst which is there, and you know pseudocyst that there is a D. Agedios classification. This D. Agedios classification is that one type of cysts are seen in acute pancreatitis and usually they don't communicate with the duct, main pancreatic duct. Type 2 can be seen in acute or chronic and they can communicate with the duct, and type 3 is usually seen in chronic pancreatitis and there is invariably a communication with the main pancreatic duct. Now, all pseudocysts don't require management. In fact, majority of the pseudocysts will resolve spontaneously. Only those which are more than 6 centimeters in size, more than 6 weeks old, or the wall thickness is more than 6 millimeters, only those pseudocysts require intervention. This was asked once in the INI-CT exam. You have a 42-year-old patient who came with recurrent abdominal pain and weight loss. Serology showed raised IgG4 levels and the MRI revealed some abnormality. You can see here the pancreas on CT is bulky, it is inflamed. So, inflammation of the pancreas is known as pancreatitis. But what kind of pancreatitis is this? This is autoimmune pancreatitis, right? Autoimmune pancreatitis. You will have jaundice, weight loss, and you will get a sausage like appearance of the pancreas, which I've shown you here. Now, chronic pancreatitis, there are various causes which you can remember as the mnemonic TIGAR-O. Now, within this TIGAR-O, G stands for genetic or hereditary. And these are two genes which I want to mention to you because they've also been asked in the INI-CET exam. You have the SPINK1 gene which is seen in tropical calcific pancreatitis, where you have the PRSS1 gene which is seen in hereditary pancreatitis. Right, I've already told you that IgG4 can be raised in autoimmune pancreatitis. Now, this question is, you need to read it carefully because if you don't read it carefully, you can go wrong. A patient suffering from cirrhosis, right? So, they've given a hint that the patient is suffering from cirrhosis, is ready to undergo surgery for perforated appendix. Which of the following scores would be used to assess surgical mortality? Now, in a patient with cirrhosis or any liver problem, whenever we are doing surgery, there is a risk of mortality, and that risk of mortality worsens or increases if the liver function further deteriorates, which is why we use the child Pug Turcotte score, right, to see what is the prognosis post surgery in a patient who has cirrhosis. The MELD score is the model for end stage liver disease score that can also be used in adults, but for your exam, if you have to choose, you will mark child book score in this patient. You need to memorize the child book score. This has been asked many times. It includes encephalopathy, ascites, bilirubin, albumin, and prothrombin time. And each parameter is ranged from 1 to 3. And if the score is 5 to 6, it is least severe cirrhosis or least severe liver dysfunction. B is moderately severe and C is most severe liver dysfunction. So the mortality will also be very high even if you're doing a non-liver procedure. This is the MELD score. The MELD score includes the serum bilirubin, INR, and creatinine. And those who are preparing for the INI-CET exam, all these scores are very important for you because they are frequently asked in the exam. So you need to remember the child book score and the MELD score as well. This is the PELD score, the pediatric end liver disease score, which includes albumin, bilirubin, INR, growth failure, and age. A patient admitted for routine checkup on CT. The following finding was seen on CT. What is the most probable diagnosis? This you can see the classical lesion in the liver, which is showing a central stellate scar. And this central stellate scar is seen in focal nodular hyperplasia. And this central stellate scar is nothing but the arteriole, which is radiating outwards. Now, these patients of FNH are usually asymptomatic and you don't need to do anything. You just need to keep these patients under observation. So this is focal nodular hyperplasia. Focal nodular hyperplasia is a benign condition. There is decreased blood supply, which is one of the etiologies. And you can see Kupffer cells, which is why it shines on a sulfur colloid scan. But the classical finding is a central stellate scar, and we usually conservatively manage these focal nodular hyperplasias. So this question is the one which most of the students got wrong and they found tricky. Now this is particularly relevant for the PG exams, not for the MCI exams. According to the Strasbourg classification of bile duct injury, injury to the right aberrant posterior sectoral duct with obstructed duct is what type of injury? So the correct answer here is type B. Strasbourg is the correct answer, which we can evaluate using an MRCP, not an ERCP. ERCP is invasive, where you need to cannulate the papilla. Here, MRCP, magnetic resonance, is right? It is not invasive. You're not doing a procedure, so the complications are less. Right, so this is the bismuth and the Strasbourg classification. Again, this has only been asked once in the INI-CET exam, otherwise it has not been asked. Now, small leaks from the cystic duct are Strasbourg A. Occlusion of an aberrant right hepatic duct is B, which is what was mentioned in the question stem. Leak from an aberrant right duct is type C. Lateral injury to CBD is D. And then you have 1 to 5 or E1 to E5, both of them mean the same thing. Now I want to discuss some questions which are other than what I had given in the quiz as well, because from the hepatobiliary system, one of the favorite questions which the examiner asks is what is going to be the next investigation, and students are often confused between MRCP and ERCP. So that is the confusion which I want to sort out here. So you have a 56-year-old patient with surgically obstructed jaundice, right? So surgically obstructive jaundice would mean that the direct bilirubin is raised, ALP is raised in these patients, and here you have a distended gallbladder with dilated CBD and intrahepatic biliary radicals as well. Right, so basically what this means is that the intrahepatic radicals are dilated, gallbladder is dilated, CBD is dilated. Now, when will this happen? This will happen when something is blocking the opening of the CBD and the pancreatic duct. So, probably a cancer in the head of the pancreas or any of the periampullary cancers. Now, to evaluate these periampullary cancers or to see them better, I would want to do an imaging. And I would want to do an imaging which is non invasive. So, here I would like to do MRCP, magnetic resonance cholangiopancreatography. This you can see is an MRCP. And how do we first thing differentiate between MRCP film and ERCP film? This is MRCP, this is ERCP, endoscopic retrograde cholangiopancreatography. And in an ERCP film, you will always see the endoscope, whereas in an MRCP film, you will never see the endoscope. So that is how we differentiate. And when we do an MRCP in such a situation, you can get a double duct sign in such a patient. So this was one question. This is another very common question which is asked. A patient underwent a lap chole. In the postoperative period, the patient develops fever and tachycardia. The WBC count is raised. Ultrasound shows a 5 into 5 centimeter collection in the right hypochondrium. Right, so patient had a lap chole and now the patient has developed fever and tachycardia, and TLC is also raised. All these are suggestive of a leak, right? An injury to the bile duct, and there is a leak, and that is confirmed on an ultrasound that there is a collection there. Now, I want to see what is the nature of the leak, where is it leaking from, right? Which vessel or which duct has been injured, and then I have to take action, right? So before I do that, in such a patient who's already symptomatic, I first need to control the symptoms. So in such a patient, the first thing which I will do is ultrasound guided pigtail catheter drainage to drain out the collection. Second, in this patient, right, we will do an MRCP to look for the leak, where is the injury, and then we can do an ERCP in these patients and we can put a stent across the leak. ERCP can be both diagnostic and therapeutic because you can use it for stenting, you can use it for retrieval of stones, but first we will confirm by MRCP. Now, this is another situation. A patient with multiple gallstones undergoes an ultrasound, right? So, the patient has gallstones, has undergone an ultrasound, which reveals the CBD diameter to be 12 millimeter and serum bilirubin is 0.8, ALP is raised, it is 380, and GGT is 5 times raised. So, now we have a patient who has CBD diameter is increase. So CBD diameter more than 10 millimeter, we the alarm bells start ringing that there might be a stone in the CBD which might have dropped from the gallbladder. Now, how do we confirm this? So, ultrasound is not a good modality to look at the CBD, right? Because the lower half of the CBD you cannot see. So here again, first I just want to confirm whether there are stones or not. And to do that, what will you do? ERCP or MRCP? I told you MRCP is non-invasive. So we will start with magnetic resonance cholangiopancreatography, and that is what will show us stones in the CBD, and then I can do an ERCP to retrieve those stones. Right? So always remember this. This is the ready reckoner which I have prepared, which will help you in answering questions. The investigation of choice for gallstones and for cholecystitis both, right? Even for cholecystitis, the investigation of choice is ultrasound. The investigation of choice for CBD stones, I just told you, common bile duct stones is MRCP. But if you have very small CBD stones, which are known as CBD microliths, you can do an endoscopic ultrasound. The gold standard investigation would be ERCP because it is therapeutic as well, but because it is invasive, we usually do MRCP first. The investigation of choice for CBD strictures is MRCP. Small bile leakage after cholecystectomy. If there is bile in the drain, patient is stable. If there is very minor leak, you monitor. But like I showed you in one of the scenarios, if the patient is symptomatic, that means fever, jaundice, tachycardia, then you will put in an ultrasound guided pigtail. Then we do MRCP and then ERCP and stenting. So that is how we manage this, and this is just a summary of the investigations which is asked quite frequently. So the first quiz was on GIT, and the first question which was there was that a patient with pain during defecation and presence of red blood on toilet paper, he comes to the OPD. He also complains of constipation and was diagnosed with a chronic anal fissure. What is the preferred procedure to manage this given condition? So they've already mentioned the diagnosis in the question, and you can see the chronic anal fissure. We know that anal fissures are more common at 6 o'clock position, which is the posterior midline. So that is where this fissure is, and these fissures are extremely painful. That is why the patient has pain, constipation. Now, initially, we do conservative management in terms of sitz bath, laxatives, applying xylocaine jelly. But if it does not work out, then we can do a lateral anal sphincterotomy. Now, lateral anal sphincterotomy, we are cutting the internal sphincter, because if we cut the external sphincter, there can be incontinence, which is why the internal sphincter is cut. Another surgery for anal fissures is anal advancement flap. Thier's procedure, you know, is for rectal prolapse, right? And this is a perineal procedure for rectal prolapse. Milligan-Morgan is used for hemorrhoid surgery, and transanal resection is used for early cancers or polyps. Now, I've told you anal fissure is a breach in the continuity of the anal epithelium. Posterior midline is the most common, and the investigation of choice is external inspection. We don't carry out digital rectal examination because it is extremely painful. We initially try lifestyle management. If it does not work out, then we do sitz bath, right? Sitz bath along with lifestyle management is initially advised, and if it does not work out, then we do surgery in terms of lateral anal sphincterotomy and anal advancement flap. You know, chronic anal fissure will have a skin tag or a sentinel pile. This is usually associated with a chronic anal fissure. The second question has also been asked many times in the exam. A patient is diagnosed with left sided colon cancer. What is the most common presenting complaint? So, most common presenting complaint of left-sided colonic cancers are annular or apple core kind of growths, and they will come early with irregular bowel habits. And because they are annular growths, these patients will land up with obstruction and constipation. So those would be the early features for left-sided lesions: obstruction and constipation. Whereas right-sided lesions are ulceroproliferative, and these lesions can bleed, and when they bleed, the patient can come with iron deficiency anemia, right? That is why any elderly patient who's coming with iron deficiency anemia, we should always be careful, and we should always try to rule out a right-sided colorectal cancer. So the patient will come with constipation or early signs of change in bowel habits. So right-sided lesions, I told you, are exophytic, whereas left-sided lesions are napkin ring type of lesions. They're constricting. So if you go to a fancy restaurant, you will see that the napkin has a ring around it, and it is constricting the napkin. So the growth is also doing the same. And if you do a barium in these patients for left-sided lesions, it is also known as apple core deformity, and this has also been asked in the exam. The third question is a 48-year-old lady who's come with abdominal pain, weight loss, fever, and loss of appetite. The barium image is shown. What is the probable diagnosis here? So you can see that this is a barium meal follow through. BMFT, barium meal follow through, is good for the small bowel and for the ileocecal junction. And you can see that this is the ileocecal junction, and you can see that there is a narrowing or constriction here in the ileocecal junction, right? So there is a stricture in the terminal ileum, right? There is stricture in terminal ileum, and the ileocecal junction is pulled up, right? ICJ is pulled up. This is typically known as the goose neck deformity or the swan neck deformity, and this can be seen in ileocecal tuberculosis, which again is going to come with abdominal pain, weight loss, fever, and loss of appetite, right? So this sign of stricture of the terminal ileum can also be seen in Crohn's disease, but that was not mentioned as one of the options, which is why here the answer is going to be ileocecal tuberculosis. The fourth question is an 18-year-old who presented with inability to swallow since last 1.5 months, leading to weight loss. Dysphagia is more with solids, and there is no past history of similar episodes. CT angiography is shown what is the most probable diagnosis. So the patient is coming with dysphagia, and dysphagia, if they are showing you the CT angio, they are indirectly hinting that it has to be a vascular cause. And there is only one vascular cause which gives rise to dysphagia, and that is dysphagia lusoria. Dysphagia lusoria is because of aberrant right subclavian artery. So if you look at the CT image, they had labeled it as ARSA. I had made sure that I write as ARSA, otherwise it would have been a difficult question just to diagnose on the CT. Right? So this is dysphagia lusoria, which is due to an aberrant right subclavian artery, which can cause dysphagia. And this dysphagia is usually intermittent and non-progressive dysphagia which is there. Now question number 5, an infant is born with a history of polyhydramnios in utero. So the mother had polyhydramnios and the child had difficulty in breathing immediately after birth. Examination showed frothing of the mouth. A provisional diagnosis of a tracheoesophageal fistula is made. Which fistula is most common? So here we know that type C is the most common fistula, and tracheoesophageal fistulae, the mother will be having polyhydramnios. Now A stands for atresia, means both the ends of the esophagus are not communicating with each other. B is when the proximal end communicates with the trachea, distal end is blind ending. C is the most common. C is when the proximal end is blind ending, but the distal end communicates with the trachea. D is when both ends communicate with the trachea. And E is when the esophagus is patent, but still there is a communication. E is also known as the H type. Now, the child is going to come with respiratory distress, excessive drooling of saliva, which I had mentioned in the clinical scenario. And the confirmatory test here is a contrast study, which is iohexol is better than dinosil here. A contrast study will delineate the anatomy of the fistula. For H type, and this was asked once in the exam, the H type, it is combined tracheoesophagoscopy. And remember, in a child, whenever any congenital anomaly is detected, always rule out other congenital anomalies before you start managing the patient. Now, question number 6. Which of the following is not a feature of external hemorrhoids? Lined by columnar epithelium, located proximal to the dentate line, painful, and excision is the preferred modality. Now, external hemorrhoids are distal to the dentate line, so this is wrong, right? This is a wrong thing. And external hemorrhoids can be painful because they are below the dentate line. They will have somatic nervous supply and they can be painful. Excision is the treatment modality. This is correct. A is also wrong because external hemorrhoids are lined by squamous epithelium and not columnar epithelium, whereas internal hemorrhoids can be lined by transitional or columnar epithelium. So in this question, there are two answers or two options which are Not true. It is lined by squamous epithelium and they lie distal to the dentate line. So please make sure in the PDF only one was there, but I'm telling you that there are two options which are wrong here. Now this is what external hemorrhoids look like. You can see the hemorrhoids outside. These are thrombosed hemorrhoids which are there, right? And you need to know the 4 grades of hemorrhoids. They've been asked many times in the exam. Grade 1 are only which bleed, they don't prolapse. Grade 2 are the ones which prolapse out, means they will come out but they will spontaneously go back inside. 3 are which prolapse but need to be pushed inside, and 4 is which remain prolapse. 1 we just manage by lifestyle changes which are similar to what we discussed for anal fissures in the starting of the video. Grade 2 you have to do management for grade 1, plus we will either do banding or we will do sclerotherapy, right? And out of these two, banding is better than sclerotherapy. Grade 3 and grade 4, the management is like grade 2, plus we have to carry out surgery. And the latest surgery for hemorrhoids these days is stapler hemorrhoidopexy. A febrile patient is brought to the hospital with complaints of severe abdominal pain. He is tachycardic on examination and CT shows the findings below. Which of the following is not a sign seen in the above image or the above disease? So actually what was here was that there was an inflamed appendix which was there. Now for some of you this might be difficult to just pick up inflamed appendix on a CT without more clues. So how do we solve this question? Otherwise we look at the options. Now we know that Aron sign is a typical sign of appendicitis, right? And Aron sign is pain in the epigastrium. Tenhorn sign is when you pull the right testis, there is pain in the right iliac fossa, right? And you also had the bacillar sign. The bacillar sign is also for acute appendicitis, right? Bacillar sign was done earlier. It is not mentioned in the books. It is when the thumb is pushed posteriorly, this will cause the appendix to be pinched against the iliac muscles, and this can cause pain. So these 3 signs are of appendicitis. Balance sign is seen in splenic rupture, right? So balance sign is not a sign of appendicitis. So we can even rule this out by elimination. A male presented with bleeding during defecation and frank blood is seen. A reddish mass is seen hanging from the anal opening. It does not reduce spontaneously, neither is reducible manually, right? So I told you which cannot be reduced either spontaneously or by manual reduction. This is a 4th grade hemorrhoid you can see here, and this would require surgery, which I've already mentioned to you. What is the instrument mentioned here? You can see this is a right angle retractor, a null self-retaining retractor. This is known as a Langenbach retractor, which is used for open cholecystectomy, right? A modification of Langenbach is a Morris retractor. Morris retractor is wider than Langenbach, and that is also used for open cholecystectomy. This one is known as a Zerny retractor or an Army Navy retractor, where one side you have a solid right angle, whereas on the other side you have 2 hook-like things and there is some gap between them. So this is a Zerny's retractor. This is a Babcock's forceps, right? This is a Babcock's forceps, and this Babcock's forceps, what happens is that you can see there is some space here, and in this space we can hold tubular structures. Tubular structures like appendix, like fallopian tube, vas can be held, and because there is some daylight there, it is non-traumatic. This is a Doyen's retractor. A Doyen's retractor, you can see the curve, it is curved. Unlike it being right angle like Langenbach or Morris, this is curved, and this is also used for retracting the bladder. A 45-year-old patient comes with vomiting and severe abdominal pain. On examination, the abdomen is significantly distended and tender to touch. Hyperresonance is observed on percussion. X-ray is shown below. What is the next step in the management? Right, so if you see the X-ray in this case, this is a typical coffee bean sign which we are going to see. Right, coffee bean sign which we are going to see, and this coffee bean sign is suggestive of sigmoid volvulus. Now, some of you were saying that why isn't it cecal volvulus? Why is it sigmoid? So let me explain to you why is it why is this a case of sigmoid volvulus. So whenever you have a case of sigmoid volvulus, you will also see other loops of large bowel, right? Large bowel would be seen, and you can see the loops of large bowel here. You can see the loop of large bowel here as well. So if the large bowel is distended, that means you're dealing with sigmoid volvulus. But if it was cecal volvulus, if the cecum was rotating, the bowel distal to it will be collapsed. So the large bowel will not be distended in that case, right? So that is one main sign which helps us in differentiating. Another sign is that the apex would point towards the right shoulder tip, right? So apex of sigmoid volvulus points towards the right shoulder tip, and I've told you, you will see dilated large bowel in which you will see hostrations. Hostrations don't go from one wall to the other wall completely. Unlike small bowel you will have complete volvulae in the jejunum, right? In the jejunum. But hostrations don't go completely from one wall to the other. So this is a typical sigmoid volvulus where you get a coffee bean sign, right? And these patients, sigmoid volvulus, it usually occurs because of a long and narrow mesentery, redundant sigmoid and a loaded sigmoid, and anti-clockwise rotation is more common, and this is common in patients who are on antipsychotic medications. Also, if you do a barium enema in these patients, you can get a bird's beak sign, right? So these were the 10 questions which I wanted to discuss. All of them are important, and like I said, they cater to all students who are preparing whether for FMG or for PG. First, let's start with GIT, and after each topic I will tell you the important things which you need to remember from that topic, and also the important topics from that system which you need to remember for the exam. So the first question was, what was the gold standard investigation for GERD? Now we know gastroesophageal reflux disease or GERD. The gold standard investigation is 24-hour pH monitoring. So that is the gold standard investigation which is there. Whereas investigation of choice, if they ask you investigation of choice, then it is going to be endoscopy. So investigation of choice is endoscopy, but the gold standard investigation is 24-hour pH monitoring. And when we do 24-hour pH monitoring, we measure the Demister score. We measure the Demister score when we do 24-hour pH monitoring to detect whether the patient has GERD or not. So this was a very straightforward question. The other question also has been asked previously. Identify the pathology depicted in the image below. So this was a correlation with radiology, and you can see the investigation which they have shown us here. This is known as an invertogram, right? This is known as an invertogram. And an invertogram is usually done after 24 hours, where you invert the child and you put a metallic pointer there at the proposed site of the anal opening. Okay, so this is done for imperforate anus or anorectal malformations. Now when you have this metallic pointer and you can see this gas shadow, you can see the gas shadow. Now if the distance between the metallic pointer and the gas shadow, if the distance is less than 2 centimeters, we call it a low anorectal malformation. Whereas if it is more than 2 centimeters, we call it a high anorectal malformation. So for anorectal malformations, we do an invertogram, but again, the best investigation, if they ask you what is the best investigation which can delineate the anatomy in a patient with anorectal malformations, then it is MRI. So please remember these 2 points as well. Again, this was a question which was more of a clinical question, that what is the investigation which you will perform. So mother gets a child with bilious vomiting. The child has bilious vomiting. So we know that if it is bilious vomiting, the block is beyond the second part of duodenum. Okay, so that is common sense. The block would be beyond the second part of duodenum. So we have to see what is the cause. Now, barium enema will tell us about large bowel. So barium enema is out. It will tell me about large bowel. Barium meal can tell me about the stomach and duodenum, but does it delineate the anatomy very well? And in an obstructed system where there's already obstruction, if I give barium, that barium will also become obstructed, right? That barium also will not go forward. Barium swallow is mainly for esophageal abnormality, so the best answer here is going to be CECT. Contrast enhanced CT scan will tell us what is the problem which the child has. Now this was a new question, a new topic which was asked in the exam, that is choledochal cysts. And not one question, but there were actually 2 or 3 questions where they had shown images. Now this time surgery paper was slightly tricky. It wasn't as easy as the previous years, right? And the level of difficulty in the exam paper was also more, which is why you can see that the pass percentage has dropped. So the exam is becoming more and more clinical, and you need to be better equipped for that. So choledochal cyst, they had asked which is a type 3 choledochal cyst. Now choledochal cyst is when there is congenital dilatation of the biliary tree, that is called choledochal cyst. So choledochal cyst type 3 is known as a choledococele. It is known as a choledococele, and it is dilatation of the intraduodenal portion. It is dilatation of the intraduodenal portion, and you can see here this one depicts the intraduodenal dilatation. So type 1 is the most common. This has also been asked, and this is cystic dilatation, or you have cystic dilatation of the CBD, that is type 1. Type 2 is a diverticulum of the CBD. Type 2 is the diverticulum of the CBD. Type 3, I have already told you, is intraduodenal portion or choledococele. Type 4 is intra plus extrahepatic. Intra plus extrahepatic biliary radicals are dilated. And 5 is only intrahepatic dilatation. And only intrahepatic dilatation, this is known as Caroli's disease. This is known as Caroli's disease. Now the investigation of choice for choledochal cysts is MRCP. Magnetic resonance cholangiopancreatography is the investigation of choice for choledochal cysts, and this can increase the risk of cholangiocarcinomas. It can increase the risk of cholangiocarcinomas, these choledochal cysts. Okay. So these are the choledochal cysts which I have just told you. Most common is type 1. I've explained the other types to you as well. And type 4A and 5 are the ones which require a transplant for treatment. This was another image-based question. I felt it was very easy question, but because it was given in an image format, it threw some of the students off guard. So they had asked, what is the preferred incision for appendicectomy? Now we know the incisions for appendicectomy are, what are the various incisions which can be used? So you can use the McBurney's incision, right? And the McBurney's incisions are of 2 types. You can either have grid iron. Grid iron is muscle splitting incision. Grid iron is muscle splitting, whereas Rutherford Morris is muscle cutting incision. Okay. And another incision which is used is the Lanz incision. So this number 4, this is known as the Lanz incision. This is also known as the bikini incision, and it is a cosmetically better incision. I also have this incision. I was in class 7th when I had my appendicectomy, and I have a Lanz incision which is hidden in the skin crease. So you can't make that incision out. You can't see that incision. A midline incision, this is used for appendicular perforations. A lower midline incision is used for appendicular perforation. So the answer here is going to be number 4, that is Lanz or bikini incision. Now let's look at the other incisions also which have been marked here. Number 1 is a right subcostal incision. This is known as a Cocker's incision. Right subcostal incision or Cocker's incision. This is for open cholecystectomy. This is for open cholecystectomy. Number 2 is a paramedian incision. It is slightly away from the midline, paramedian incision. And number 5 is your Fannin steel incision. Is the Fannin steel incision. This is used for cesarean sections. Number 5 is Fannin steel. This is used for cesarean sections. So you should know these incisions for your exam. Which fluid will you prefer in a patient who's come to the emergency room with profuse vomiting and metabolic alkalosis? So we know this, let's assume a child who has hypertrophic pyloric stenosis. And in that child we know what is the metabolic abnormality. You have hypokalemic, hypochloremic metabolic alkalosis, right? Hypokalemic, hypochloremic metabolic alkalosis. And the best fluid in these patients is first normal saline. NS is given, normal saline is given. And you should know the composition of normal saline as well. Normal saline has 154 milliequivalents of sodium and 154 milliequivalents of chloride. Ringer lactate also, the composition has been asked in the FMGE exam. You have 130 milliequivalents of sodium, 4.5 milliequivalents of potassium, 109 milliequivalents of chloride, and you have lactate, 28 milliequivalents of lactate as well. So that is why the name Ringer lactate. So in such a situation with profuse vomiting, we will use normal saline, right? Now normal saline, Ringer lactate and dextrose are crystalloids. These are examples of crystalloids. Whereas albumin is a colloid. Albumin is a colloid. Okay. A chronic alcoholic patient with liver disease presents with melena and hematemesis. What is the most likely cause? So the patient is having upper GI hemorrhage. Hematemesis means blood in the vomitus. And because there is blood in the upper GI, you are getting black tarry stools as well. That is called melena, right? Now, what are the various causes of upper GI hemorrhage? Varices can be there, Mallory-Weiss tear can be there, Boerhaave can be there, duodenal ulcer. So all are causes. Now, the hint which they've given is that this patient is chronic alcoholic. So in chronic alcoholic, right, you can get Mallory-Weiss tear, right, which can occur because of splitting of the mucosa and the submucosa. But more common in these chronic alcoholic patients will be esophageal varices. Okay, so varices will be the best answer here, and the hint is chronic alcoholic patient. That is why esophageal varices would be a best answer. Now, Boerhaave syndrome is perforation, right? So esophageal perforation can be of two types. You can either have iatrogenic perforation or you can have spontaneous esophageal perforation. Iatrogenic perforation is after endoscopy, right? You do an endoscopy and the esophagus perforates. This is more in the upper 1/3, and usually these patients are stable and they don't require surgery, right? So majority are small stable patients. You do conservative management in these patients. That means you will make the patient nil per oral, give IV fluids, IV antibiotics and analgesics. Spontaneous esophageal perforation is called Boerhaave syndrome. This has also been asked frequently in the exam. This perforation occurs after forceful vomiting, and this commonly occurs in the lower 1/3 of the esophagus, the left posterolateral wall. And you should know about the Mackler's triad in spontaneous esophageal perforation, that is retching, chest pain and surgical emphysema. This has also been asked in the exam. This is a Mallory-Weiss tear. A Mallory-Weiss tear, I told you, is a split in mucosa and sometimes submucosa. This is also seen in alcoholic patients, common in alcoholic patients after vomiting. And usually the bleeding is self-limiting. In Mallory-Weiss tears. Now, a patient underwent this surgery a few months back and he complains of dizziness, headache, sweating 40 minutes after consumption of food. So you can see here that this patient has had a bariatric surgery. Okay, this patient has had a bariatric surgery and this is a Billroth reconstruction. If you remember your classes, I've taught you about Billroth reconstruction, right? So this Billroth reconstruction, this can give rise to dumping syndrome and headache, sweating, tachycardia after 40 minutes. These are all signs of late dumping. Okay, these are all signs of late dumping. So let's read about dumping syndrome. Now, dumping syndrome can be of two types. You can either have early dumping or you can have late dumping. Early dumping occurs when more fluid comes into the bowel as soon as the patient eats food. And when that happens, the patient is going to have bloating, nausea, vomiting. Right, those will be the features and they will occur almost within 10 to 15 minutes of eating food. And also, the patient eats more food, there will be more bloating and more vomiting. Late dumping, on the other hand, you should know it occurs because of rebound hypoglycemia. So more insulin is secreted and that can give rise to rebound hypoglycemia. That is why the features are headache, sweating, tachycardia. Now this will improve with more food and these symptoms usually occur after 30 to 40 minutes. Now, because they've started asking about dumping syndrome, you should know how do we prevent dumping syndrome. So we can prevent dumping syndrome by small frequent meals, by avoiding liquids with meals, by avoiding simple sugar and sugar rich liquids, and in resistant cases we can use octreotide as well. We can use octreotide as well in these patients. Now, what is the most common complication after bariatric surgery? So this was a very straightforward question. The most common complication following bariatric surgery is iron deficiency anemia. And even last year, there were two questions in the last FMGE exam from bariatric surgery complications. One was regarding iron deficiency anemia. The other one was regarding vitamin B12 deficiency. So iron deficiency is the most common nutritional deficiency following bariatric surgery. Vitamin B12 deficiency can also occur, but this will give rise to megaloblastic anemia. So that was what was asked last year. This is going to give rise to megaloblastic anemia. Calcium deficiency can also be seen. Protein energy malnutrition is only seen in certain types of bariatric surgeries like duodenal switch, and BPD, that is biliopancreatic division. Not in all bariatric surgeries you will not see protein energy malnutrition. Now this I feel is a constant question. Every year this question is asked in the exam about gas under diaphragm. So you have a 26-year-old male who's been brought to the emergency with abdominal pain and obstipation. Okay, he had a bull gore to the abdomen 3 days back, means a bull injury. A bull went into his abdomen and the horns went into the abdomen. His x-ray is given below and we can see gas under the diaphragm, right? We can see gas under the diaphragm and we know gas under the diaphragm is a sign of hollow viscous perforation. This is seen in hollow viscous perforation. That is where you see it, and this is asked every year. They will either tell you that a patient has consumed analgesics and then has developed pain abdomen, so after NSAIDs there is an ulcer which is perforated, or it can be traumatic pneumoperitoneum as well. So a patient is diagnosed with the pathology shown in the image. She should be referred to which specialist? So I'm sorry, the image you cannot see, but this was an image of trichobezoar. This was an image of trichobezoar. Trichobezoar is a hair ball. This is a hair ball inside the stomach. And we know that this is a psychiatric ailment in which there is first trichophagy, means the patient starts eating his or her own hair and it forms into a hair ball that is called trichobezoar. I'll share the image as a link and you can watch that image as well. So this question has been asked previously also in the exam. Now a patient undergoes cholecystectomy a few days back and now comes with fever and jaundice. Okay, so cholecystectomy was done. Patient has come with fever and jaundice. MRCP, magnetic resonance cholangiopancreatography, bile leakage is noticed. So you notice bile leakage here. Now what should be the management of this patient? Now we know that it has been few days. It has been few days in this patient. So because it has been few days, we cannot re-explore. Because if we try to re-explore, then the sutures will not hold. So if it is few days later, we will do ERCP and stenting, endoscopic retrograde cholangiopancreatography. So we will do endoscopic retrograde cholangiopancreatography, and we are going to put a stent through the leak, right? Stent through the leak so that the leak stops. This question also has been asked many times in the exam. Which tumor can present with a necrolytic migratory rash? So necrolytic migratory rash is classical of glucagonoma. Okay, insulinoma, you know the patient will come with Whipple's triad. Whipple's triad is fasting hypoglycemia. This is fasting hypoglycemia. Okay, and you have blood sugar less than 40, and the symptoms get relieved. Symptoms get relieved on taking glucose. On taking glucose, the symptoms will get relieved. Glucagonoma, these patients are going to come with diarrhea. They will come with dermatitis or necrolytic migratory rash. They will come with diabetes mellitus and dementia as well. Right, so these are the points which we need to know in insulinoma and glucagonoma. You should know that insulinoma is the most common pancreatic endocrine neoplasm. Okay, so this is the necrolytic migratory rash which you can see in glucagonoma. Insulinoma, I told you that the patient will come with Whipple's triad. It is the most common neuroendocrine tumor or pancreatic endocrine tumor, in pancreas, and 90% are benign. Now, VIPoma, vasoactive intestinal peptide tumor, this can give rise to WDHA syndrome or Werner-Morrison syndrome. So, in VIPoma or WDHA syndrome, you get watery diarrhea, hypokalemia, achlorhydria, and acidosis. This has not been asked in the exam as yet, but insulinoma and glucagonoma both have been asked in the exam. Very simple, and this was a very I would say a common sense question which was asked. What advice would you give to a patient who is being planned for laparoscopic cholecystectomy? So this time the questions were very clinically oriented, lots of questions from GIT, and they were very practical questions. I mean, even if you haven't read, but if you've gone to the ward, if you know how a patient is prepared, you can answer a lot of questions. So patient is planned for laparoscopic cholecystectomy. What advice will we give to the patient? Eat full before surgery? No, we don't want to do that. Drink plenty of fluids? No. Enema at night? So we are not doing a bowel surgery, right? So if you are not doing bowel surgery, why do we want to give enema, right? Avoid solid foods for 6 to 8 hours before surgery. That is correct. This is correct. Water, sips of water you can take up till 2 hours before as well. Sips of water can be taken up till 2 hours before as well. Clear liquids can be taken up till 4 hours before as well. Clear liquids can be taken till 4 hours, water till 2 hours, but solid foods we need to keep the patient fasting for 6 to 8 hours. A 16-year-old male comes with bronchospasm. On investigation, the tumor is found in the ileum and has increased 5-HIAA. What is HIAA? 5-hydroxyindole acetic acid in the urine. So what is the diagnosis here? The diagnosis is going to be carcinoid syndrome. We know in carcinoid syndrome, serotonin is released, and serotonin, once it gets metabolized, Once the serotonin gets metabolized, it can come out as 5-hydroxy-indole acetic acid in the urine, and this is what we can use to identify it. The most common site for carcinoid tumors is the appendix. This has also been asked in the exam. So coming to the important thing, I mean, a lot of students are asking about important topics, right? Because, whenever they are preparing, you need to lay more stress on the topics which are being routinely asked. So these are the important topics from GIT. Investigations from esophageal disorders, very important. Motility disorders, achalasia is asked very commonly in the exam. Zenker's diverticulum, not asked this year, but every alternate year Zenker's is asked. Esophageal perforations was asked, I told you. Upper GI hemorrhage every year. This is a sure short question. Upper GI hemorrhage, sure short question. Peptic ulcer perforation also asked this year, sure short question. Gastric resection and reconstruction, since the last 2 years this has become a very hot topic. They are asking at least one question from this. Bariatric surgery complications also last 2 years questions have been asked. Bowel obstruction, the investigations at the radiology you should know. Meckel's diverticulum, intussusception, duodenal atresia, volvulus are very important. Appendicectomy, this time also it was asked. Appendicular lump, you should know. Appendicitis investigations. In a child appendicitis, ultrasound is the investigation of choice, whereas in an adult it is CECT. Rectal and anal disorders. So you will always have one question from rectal and anal disorders. One question will be there. Like this time it was imperforate anus, but they've asked about pilonidal sinus, fissures, hemorrhoids as well. Liver abscess and anatomy of the liver. Gallstones, every year one question. Again, sure short question. Gallstones, cholecystectomy and its complications. MRCP, ERCP. This time they had asked choledochal cysts as well. You should know about pancreatitis investigations. Carcinoma, head of pancreas. They've asked about Whipple surgery very frequently. And endocrine tumors of pancreas, they asked 2 questions this time. So these are the important topics in GIT. Please make a note of these topics